Professor Gordon Moran is an academic gastroenterologist with a specialist interest in the management of IBD. He completed his gastroenterology training and PhD studies in the UK, followed by an advanced IBD fellowship in Calgary, Canada, with Professor Remo Paniccioni. Professor Moran is now based in Nottingham, and his primary research aims to optimize advanced imaging techniques for both inflammation and fibrosis in IBD. He leads the simple clinical trials in applied research team within the Nottingham Clinical Trials Unit. He supervises several students and fellows. He's the academic and clinical IBD theme lead within the NIHR Nottingham BRC. And as many people in the UK will know, Gordon is the current BSG Inflammatory Bowel Disease Guidelines Group lead. I'm really excited to hear your thoughts, Gordon, and the floor is yours.
Thanks for the invite, Noro, and great talk, Professor Afzali. So I'll touch on a few bits that you've presented, and please feel free to ask as many questions as you want. So I think we need to make this quite interactive. So what I'm going to touch upon is, again, a bit about isolated proctitis and the epidemiology of this. But we've done some work which I want to share with you regarding, and Professor Afzali had sort of alluded to this. What are the patient and clinician perspective regarding isolated proctitis or refractory proctitis? What do actually patients think about the way we manage this, or clinicians? And what is the present evidence on the management of isolated proctitis? And we'll probably all acknowledge that the present evidence is a bit limited, because as we've just alluded today, these patients tend to be excluded from clinical trials. So we'd have to extrapolate sometimes in our management. So going forwards, the prevalence of ulcerative colitis in the Western world is approximately 1%. And how much of this is proctitis? We've heard before, approximately a third of patients present with isolated proctitis, but these extend. And essentially 24 or a quarter will progress to left-sided disease, slightly less, 15%-ish, will extend to more extensive disease over a period of 5 to 7 years. So a third of our patients will present like this, but a large proportion of them will tend to progress to more extensive disease. And a few years ago, we wanted to try and capture what is the feeling really, what is the thoughts and the opinions surrounding the management of refractory proctitis. What are we doing badly? What are we doing well? What should we do more? And we wanted to use a Delphi methodology to try and understand this. So we set up a focus group, and we invited gastroenterologists across the UK, trainees, IBD clinicians, patients with proctitis. And after that, using a focus group, we try to understand what are the key themes here, and then using a standard Delphi methodology, we optimized and tweaked these recommendations until we had an agreement of 80% or above. And this is a consort diagram showing you what the Delphi looked like. But essentially, and again, I don't expect you to read all of this, but we came up with some interesting observations and findings which probably resonate to what we've heard today. We know that patients with proctitis tend to present with rectal bleeding, but as well, they've got a lot of other symptoms which we tend not to capture. Disability, fecal incontinence, urgency, the dreaded constipation when your patient with proctitis says, you know what, yeah, the 5 ESAs are helping, I'm still having some rectal bleeding, but I'm awfully constipated. And how is this so? When I've got ulcerative colitis, I should have the opposite. So this is quite an important symptom. And so constipation is quite key. It's not measured in the typical PROs we use when we measure disease activity in ulcerative colitis. So clearly it's something important. Drug costs. How many times have we heard, oh, you've only got proctitis, so I don't feel like we should be escalating to biologics or advanced therapies. You've only got proctitis. But we've heard the effect of proctitis on quality of life. Are we doing the right thing here? And again, we've asked patients, well, if you look at British guidelines, ECHO guidelines, American guidelines, the first-line therapies are topical therapies, followed by oral therapies. But patients do not particularly like topical therapies. As we've heard, they're cumbersome, they're messy, patients don't get filled with delight when we start telling them they need topical therapy. So they prefer oral or systemic therapy. Is there a role for low-dose topical steroids, for instance, in elderly or patients with very mild disease, yeah, yes, perhaps, again, we don't like using steroids as maintenance agents, but is there a role for them? There may be. But again, this is very uncharted territory. But again, what clinicians and patients really would like to know in refractory proctitis that are refractive to 5-ASAs, refractive to oral steroids, what is the best line initial agent? What is the ideal sequencing of agents? Should we be using immunomodulator therapy and biological therapy? And yes, we should. And perhaps we're not escalating these patients enough. And then patients, sorry about that. So essentially, when patients have initial first-line therapies, are we escalating these patients to second or third line biological therapies? And what is the role of off-license therapy, for instance, tacrolimus or acetarzole, which is organic arsenic? So there's not enough research done in this field of refractory proctitis. So all in all, clinicians and patients alike feel that this area is very, very under-researched, very under-reserved. Patients are not escalated enough and appropriately enough. Patients prefer oral rather than topical therapy, and we should treat refractory proctitis very similar to more extensive disease when it's refractory. We escalate to more advanced therapies rather than not, just because patients have just proctitis.